CataractCoach.com. Case 10 for this junior resident. It's a pretty good start along the long process, long road of learning cataract surgery. Let's watch the video here. Anonymous resident, starting off with the paracentesis. I like that the eye's in primary. The microscope's in focus. The color balance seems pretty good. Illumination's good. You know what? Draping's pretty good too. So I like it so far. 2 paracenteses, a little bit of nicking of the limbal vessels, so a little bit of bleeding there from limbal vessels. I like it. Putting in probably some anesthetic. You can see the attending or professor squirting the eye with that squirt bottle, the 19-gauge cannula there. And now let's see what's next. Oh, you don't really need the trypan blue dye. To be honest, the capsule, you can see it. You got a great red reflex. Why need the trypan blue dye? Now, it does make the capsule a little bit less elastic, but I don't know if you need that. Here's the viscoelastic dispersive agent looks like, but not the best fill. See how near where the incision is going to be there temporally? It's just kind of a patchy fill. Yeah, so we'll learn from that. Here's the main incision, and that's a pretty good incision. For 10 cases in, that's your incision. I like it. Now see the rhexis. Poking in with forceps instead of using a cystotome? Are you sure? I mean, this was submitted as 10 cases. Case number 10 here. Let's watch. Now let's get the rhexis done here. Okay, poking in and see getting the rhexis done. It's reasonable. So bringing it around. I don't like that central pull at the end. As you turn the flap here, now you stop and you pull it in. Why? I don't get that. Doesn't make sense to me. So getting the rhexis done here. Obviously, we sped the video up. We can't sit here all day and wait for this case. So there we go. It's almost now. Don't make it too small here. You had a good size going. It's pretty good. For 10 cases in, I got to tell you, that's pretty good. So far, so good. Honestly, if you told me you'd done 50 cases, I'd believe it. So at 10 cases, you're pretty darn good. Not the prettiest rhexis, but you know what? You've obviously been watching some Cataract Coach videos, learn all the tricks here. Now, BSS on cannula. Let's see, hydrodissection, nice and easy. Get that eye back in primary. Yeah, okay, tolerable, I guess. Is it going to spin? If it does not spin, you will not win. Let's see what happens. I like that the attending is giving kind of advice there and saying, okay, go over here, go to this side. And I like the instruction with that 19-gauge cannula. That's fantastic. Oh, 2 hands here. Here's the attending going in with a Sinski hook, kind of rotating that thing around. The attending knows if it does not spin, you will not win. I like that. Good attending. Good job. Now, a little pinch more viscoelastic. Okay, I'll take that. Don't worry about the air bubble. It'll come out. And now let's see what's next. At case 10, if you show me phaco chop, I'm going to call you a liar. There's no genuine phaco chop at case number 10. But let's see what you do. So phaco probe going inside the eye, cleaning up some of the anterior cortical material. Okay, that's all reasonable. I'm looking at those Purkinje images in the center of the cornea. Those look pretty good, nicely centered. A groove going in here. See how the eye's out of primary? There, now I know you're a junior resident. See the eye, you need to keep that in primary. Pivot your hand, don't pivot the eyeball. See how the eye is brought there temporally as the resident does the groove? Yeah, the eye should stay in the primary and not move. So you have to pivot your hand, not the patient's eyeball. Groove's not deep enough for me. I don't know if you're going to get a crack here and propagate it all the way through. Maybe not. And it's not that dense of a cataract. It's kind of mushy. If you're a junior resident, don't do a soft case. You kind of want 2 to 3 plus NS. That's your sweet spot. If it's too soft, you're not going to be able to get your technique done. All right, you brought a piece up. For case 10, I'm taking you at your word this is case number 10. This is pretty darn good. Now, obviously, you're not a professional. You haven't done thousands of cases, I can tell you that. But for case 10, I'm pretty impressed. That's a pretty dang good job there. Getting these pieces out, the ability to use 2 hands. I mean, I know some professor-level people who've done thousands of surgeries over 20, 30, 40, 50 years who still use 1 hand. So I applaud you here. Now, remember, if you're a resident, there's the Cataract Coach free PDF book. There's a free curriculum series. You got to leave YouTube for a second and go to the Cataract Coach website. If you're a young doctor and you see me in person, say, hey, Dr. Devgan, Dr. Cataract Coach, can I take a selfie with you? I'll say, sure. Hey, have you downloaded my free PDF book? You'd be like, what? And then I'm like, yeah, I'm not feeling the selfie, right? Think about it. I mean, I do this for you for free. I take time out of my life, which is limited. I'm not 30 years old. So now cleaning up here with bimanual IA. Bimanual IA is a really nice setup, especially when you're starting off, because it gives you that full 360 access to the whole capsular bag, allows you to switch hands. By the way, you should be brushing your teeth, eating food, etc. with your non-dominant hand. Yeah, you heard it. If you're a resident and I'm taking you out for sushi dinner, you best hold those chopsticks in your non-dominant hand. So if you really want to impress me, 2 sets of chopsticks. One on the non-dominant hand, one on the dominant hand. Show me how you use your hands together. Then I'll be really impressed. But anyway, getting back to our case here. Obviously cleaning up the cortex very nicely. Beautifully done here. This is a really good case. Now, we sped the video up to 3x normal speed, and the video is about 7.5 minutes, so maybe it's like a 3 minute video in real time. That's pretty darn good for this level. I gotta tell you. What I liked in this case was that everything was in control. The surgeon, the resident was in control, and the attending didn't have a heart attack, that's a good sign. Here comes the lens going in the capsular bag. Looks like a single piece acrylic lens. Get that delivered in nice and easy. Easy does it. I like that. Get it in the capsular bag, allow it to open up. That was fantastic. So if this truly is your 10th case, my goodness, you are going to be a world-class surgeon by case 1000. Wow, wow, wow. You are far ahead of the bell curve then if it's case 10. But even if it's case 100, you're doing a great job. Don't worry. Keep up the good work. Keep getting more reps under your belt. Do more and more cases. And the patients are going to have beautiful outcomes. And you're going to learn a lot. And make sure, like you did in this case, record the video from every case, even if you don't save it. So you can at least go back and watch it and review that game day footage, because that's just going to make you a better and better surgeon. Now, hydrating up the incisions, I wish you'd do it the CataractCoach way of hydrating the roof of the incisions, not the lateral walls. But, maybe you missed those videos. So go back to CataractCoach.com, look at the website, look up incisions. There's a whole subcategory of just incisions. And it'll show you the appropriate way of hydrating them, which is not just the lateral walls. Anyway, again, all the good stuff's on CataractCoach.com. Check it out. Please, if you're a resident, download that free book. It'll help you.